Hello, my name is Dr. Tina Abraham, and I am a practicing allergist immunologist located in Rochester Hills, Michigan.
And my name is Dr. Demondes Haynes, and I'm a practicing pulmonologist and critical care physician located in Jackson, Mississippi. I'm also the Associate Dean for Admissions for the School of Medicine at the University of Mississippi Medical Center.
Thank you for joining us today as we share how we're keeping up with the shifting asthma rescue paradigm in our practices.
As respiratory specialists, Tina and I both have known for a long time that inflammation and bronchoconstriction are key contributors to asthma symptoms like shortness of breath, cough, chest tightness, and wheezing that our patients often experience. Patients may reach for their albuterol rescue inhaler when they experience symptoms, but they may not know that albuterol alone is only treating one component of asthma, bronchoconstriction. Tina, how do you talk to your patients about why they're experiencing symptoms and what their rescue can do for them?
That's a great question, Demondes. Many of my patients with asthma are aware of their symptoms and are primed to have their albuterol-only rescue on hand to use as needed. I've found, though, that I've needed to take some time to help educate them about what they're feeling. I use a visual, like the example on the screen now, to help explain why they may be experiencing symptoms such as cough and shortness of breath and what their albuterol-only rescue is doing for them. I tell them that when they use albuterol only as rescue, they're relaxing the smooth muscle and opening up the airway, which helps relieve symptoms. This is exactly what it's designed to do and helps them feel better. But then I explain that the symptoms they are experiencing are also connected to underlying inflammation. Their albuterol-only rescue doesn't address the inflammation, making it incomplete.
Great points, Tina. I started thinking about moving away from albuterol-only rescue when the GINA recommendations were first updated in support of an anti-inflammatory rescue approach in 2019. Until 2023, we didn't have an FDA-approved asthma rescue approach designed to treat both inflammation and bronchoconstriction. But now, AIRSUPRA is available to do just that. Tina, would you like to share more about it?
Of course. Let's start with the indication. AIRSUPRA is a combination of albuterol, a beta-2 adrenergic agonist, and budesonide, a corticosteroid. AIRSUPRA is the first and only anti-inflammatory rescue approved for the as-needed treatment or prevention of bronchoconstriction and to reduce the risk of exacerbations in patients with asthma 18 years of age and older. I'd also like to share some important safety information about AIRSUPRA.
Important safety information. AIRSUPRA is contraindicated in patients with hypersensitivity to albuterol, budesonide, or any excipients. Asthma may deteriorate acutely or chronically. Continued symptoms after AIRSUPRA or increasing doses of AIRSUPRA may be a marker of asthma destabilization and require evaluation of the patient and their treatment regimen. AIRSUPRA can produce paradoxical bronchospasm, which may be life-threatening. Discontinue AIRSUPRA immediately if paradoxical bronchospasm occurs. Paradoxical bronchospasm frequently occurs with the first use of a new canister of an inhaled formulation. Drugs containing beta-2 adrenergic agonists can produce clinically significant cardiovascular effects in some patients. If these occur, consider discontinuation of AIRSUPRA. Beta agonists have also been reported to produce ECG changes such as T-wave flattening, QT interval prolongation, and ST segment depression. Therefore, as with all sympathomimetic amines, AIRSUPRA should be used with caution in patients with cardiovascular disorders, especially coronary insufficiency, cardiac arrhythmias, and hypertension. Do not exceed recommended dose. Clinically significant cardiovascular effects and fatalities have been reported with excessive use of inhaled sympathomimetic drugs.
AIRSUPRA contains a SABA, albuterol, for rapid bronchodilation, plus budesonide, a corticosteroid, to address inflammation. SABAs bind to beta-2 adrenergic receptors, stimulating a rise in cyclic AMP and activation of protein kinase A, producing airway smooth muscle relaxation. Corticosteroids have a wide range of inhibitory activities against multiple cell types and mediators involved in allergic and non-allergic mediated inflammation, which may contribute to their efficacy in asthma. When AIRSUPRA became the first FDA-approved asthma rescue therapy designed to treat symptoms and inflammation and help prevent exacerbations, it was easy to have the conversation with my patients about switching from albuterol. When you take the time to explain the concept of anti-inflammatory rescue and why it's different from albuterol, that light bulb goes off for patients on why they would need a rescue designed to address their inflammation and their symptoms. Who wouldn't want the rescue that is designed to do more for them?
I couldn't agree more, Demondes. We aren't taking albuterol away from our patients when we switch them to AIRSUPRA. We're adding budesonide in there too, so we can address inflammation. The clinical data and accessibility of AIRSUPRA give me the confidence to make the switch from albuterol for all of my patients 18 years of age and older. AIRSUPRA has been studied across the entire spectrum of asthma severities. AIRSUPRA is covered for the majority of commercially insured patients, and AstraZeneca has a patient access program that features a $0 copay card to make AIRSUPRA accessible for these patients.
I completely agree, Tina. Let's take a deeper dive into the clinical data you just mentioned by briefly reviewing Mandala, which was a pivotal exacerbation study in 2,940 adult patients with moderate to severe asthma, all of whom were receiving background ICS-containing maintenance therapy. I explained to my patients and peers that the primary endpoint of Mandala was time to first severe exacerbation, and that AIRSUPRA demonstrated a superior 28% reduction in risk of exacerbation versus albuterol. In a secondary endpoint from the Mandala study, there was also a significant difference in mean annualized total systemic corticosteroid dose. Before we move on to safety, I do want to note that although patients 12 to 17 years were included in the Mandala trial, AIRSUPRA is not approved in this age group. Therefore, the efficacy results I presented only apply to adults greater than or equal to 18 years of age. Mandala demonstrated a safety profile similar to albuterol, regardless of background inhaled corticosteroid dose, which both patients and providers should be made aware of. The following adverse reactions for AIRSUPRA occurred with an incidence of greater than or equal to 1%, headache 4.3%, oral oropharyngeal candidiasis 1.3%, and cough 1%, compared to headache 4.9%, oral oropharyngeal candidiasis 0.5%, and cough 1.1% in the albuterol arm.
That's great to know. It's also really important to me that my colleagues understand the Denali study, which was a lung function study in 964 adult patients with mild to moderate asthma. Before we discuss efficacy, I want to point out that while patients 12 to 17 years were included in Denali, AIRSUPRA is not approved in this age group. Therefore, the data shown only reflect efficacy in adults greater than or equal to 18 years of age. When I review efficacy data with colleagues, I like to highlight that AIRSUPRA has an onset of bronchodilation as fast as albuterol, as shown by a similar median time to onset of bronchodilation of 7.5 minutes versus 10 minutes with albuterol. In Denali, the following adverse reactions for AIRSUPRA occurred, with an incidence greater than or equal to 1%. Headache, 5.1%, dysphonia, 2%, and oral oropharyngeal candidiasis, 1.5%, compared to headache, 7.1%, dysphonia, 0%, and oral oropharyngeal candidiasis, 0% in the albuterol arm.
Thanks, Tina. As a final point, I really want to stress the importance of getting the word out about AIRSUPRA to other specialists treating asthma. In my personal experience, when patients go to the ER or urgent care for an exacerbation, they usually don't see a pulmonologist and they're still going home with albuterol. In my opinion, we need to make sure specialists such as ER physicians and hospitalists know that AIRSUPRA is an asthma rescue option for their patients that may reduce the risk of exacerbations. Would you agree with that, Tina?
Absolutely. Anyone caring for patients with asthma needs to hear this. I also think that there's an opportunity to educate medical students and new physicians about AIRSUPRA during their training. When new practitioners understand the science, they can change the landscape.
Thank you for listening to our thoughts on shifting the asthma paradigm with AIRSUPRA, the first and only FDA-approved anti-inflammatory rescue for asthma that treats bronchoconstriction and helps prevent exacerbations. We invite you to review the full prescribing information for AIRSUPRA, including patient information, at AIRSUPRAHCP.com. Please continue to watch for important safety information.
Hypersensitivity reactions, including anaphylaxis, can occur after administration of albuterol sulfate and budesonide, as demonstrated by cases of anaphylaxis, angioedema, bronchospasm, oropharyngeal edema, rash, and urticaria. Discontinue AIRSUPRA if these occur. Like all therapies containing sympathomimetic amines, AIRSUPRA should be used with caution in patients with convulsive disorders, hyperthyroidism, or diabetes mellitus, and those unusually responsive to sympathomimetic amines. Beta-adrenergic agonists may produce significant hypokalemia in some patients. Decreased serum potassium is usually transient. Due to possible immunosuppression from the use of ICS, worsening of infections can occur. A more serious or fatal course of chickenpox or measles can occur in susceptible patients. Oropharyngeal candidiasis has occurred in patients treated with ICS agents. Monitor patients periodically. Advise patients to rinse their mouth with water without swallowing after inhalation. Hypercorticism and adrenal suppression may occur with very high doses in susceptible patients. If these occur, consider appropriate therapy. Decreases in bone mineral density have been observed with long-term administration of ICS. Regularly assess patients at high risk for decreased bone mineral density. Glaucoma and cataracts have been reported following long-term administration of ICS, including budesonide. Orally inhaled corticosteroids, including budesonide, may cause a reduction in growth velocity in pediatric patients. The safety and effectiveness of AIRSUPRA have not been established in pediatric patients, and AIRSUPRA is not indicated for use in this population. The most common adverse reactions are headache, oral candidiasis, cough, and dysphonia. AIRSUPRA should be administered with caution to patients being treated with strong cytochrome P450-3A4 inhibitors, which may cause systemic corticosteroid effects, short-acting bronchodilators. Concomitant use of additional beta-agonists with AIRSUPRA should be used judiciously to prevent beta-agonist overdose. Beta blockers, which may block pulmonary effects of beta-agonists and produce severe bronchospasm. Diuretics, or non-potassium-sparing diuretics, which may potentiate hypokalemia or ECG changes. Consider monitoring potassium levels. Digoxin, which may decrease serum digoxin levels. Consider monitoring digoxin levels. MAOIs or tricyclic antidepressants. Use AIRSUPRA with extreme caution, as these may potentiate the effect of albuterol on the cardiovascular system. Use AIRSUPRA with caution in patients with hepatic impairment, as budesonide systemic exposure may increase. Monitor patients with hepatic disease. These are not all of the side effects for AIRSUPRA. Visit www.AIRSUPRAHCP.com for additional information, including full prescribing information and patient information.